The compression of a cranial nerve by a blood vessel has for 50 years been recognized as a cause of trigeminal neuralgia for the fifth cranial nerve with stabs of pain in the face, and for glossopharyngeal neuralgia for the ninth cranial nerve with stabs of pain on one side of the throat and in the ear, and for 40 years for hemifacial spasm with facial twitching. The most common causes of recurrent vertigo attacks are Meniere's disease and vestibular migraine. Recognition that a vascular compression of the eighth cranial or vestibulocochlear nerve could be a cause of vertigo attacks, tinnitus, and other symptoms has been slow. Early evidence came from pioneering otoneurosurgeons in an era of less precise imaging. MRI scanning with 3D Fiesta sequences has enabled more precise imaging of vessels around the eighth nerve when this diagnosis is being considered. The video shows a pulsating antero-inferior cerebellar artery, or ACA, which has worn away the myelin covering of the left superior division of the eighth nerve in a woman who for 5 years had experienced motion sickness, visual evoked vertigo, and then vertigo attacks lasting at least 2 hours with a hissing and pulsating sound in her left ear, followed by an occipital headache. Separation of the compressing vessel from the nerve abolished all symptoms immediately and for 18 years. She died from an unrelated cause. 3 studies on the 5th, 7th, 8th and 9th cranial nerves show a difference in the length of their central nervous system segments, covered by oligodendral myelin, compared with their more peripheral segments, covered with Schwann cells. The 8th cranial nerve has the longest central nervous system segment. This predicts that it would be the most vulnerable to microvascular compression. An extensive experience at the University of Munich with patients with 8th nerve microvascular compression symptoms has led to the Barony Society, an international vestibular disorder society based in Sweden, recognizing and naming the condition Vestibular Paroxysmia with diagnostic criteria. They stress the brevity of the vertigo attacks, usually lasting only seconds or minutes, that episodes can be triggered by head movements, and that there is usually a response to carbamazepine. Vestibular paroxysmia should be considered in a patient presenting with very frequent and usually brief vertigo attacks lasting seconds or minutes. However, they can be much longer and can be confused with Meniere's disease and vestibular migraine. There is a large radiological literature attempting to correlate small vessel relationships around the eighth nerve. They invariably conclude no relationship to the patient's symptoms. Microvascular compression from an ACA should be considered when the vessel is passing over and not through the superior vestibular nerve from its entry to the brainstem and as far lateral as its midpoint. It is essential that proof of unwitnessed brief vertigo attacks is verified with a recording of a so-called irritative nystagmus beating to the symptomatic side. A mobile phone recording should be obtained by the patient, a family member, a friend, or a work colleague. Meniere's disease and vestibular migraine should be excluded. Symptoms are usually controlled with carbamazepine or gabapentin. In severe and poorly responding cases, decompression of the nerve may sometimes be justified. The MRI scan shows an ACA vessel looping over the right vestibular nerves near the brainstem in a 39-year-old male with a 2-year history of very frequent and brief video-documented vertigo attacks lasting seconds or minutes, often triggered by head movements.